So, good morning, all of you. So, you're able to see my slides and able to hear me, right?
Yes, sir. We are able to see you and your slides, and we are able to hear you also, sir. Thank you, sir.
Thank you, sir. So, before we proceed with the visual fields in neuro-ophthalmology, we need to know a little bit about the terminologies which we use and the arrangement of the nerve fibers along the visual pathway. So, first, we need to know the difference between homonymous and heteronymous. So, what is homonymous? Homonymous means it is on the same side, that is either on the right side or the left side. So when we draw a visual fields, we draw as what the patient sees. So this would be for the right eye and this would be for the left eye. However, when we draw a fundus diagram, it would be the reverse, like what the doctor sees. So right eye would be drawn on this side and left eye would be drawn on this side. So with regards to the visual fields, it is the opposite. Okay. So when we call homonymous, it will be on the same side. So for example, this is the right visual field and it's on the, this field effect is on the left side of the right eye. And similarly for the left eye, again, we have it on the left side of the left eye. So this would be left homonymous hemianopia. What is hemianopia? Anopia means non-seeing area. Hemi means half. So half of the visual field is gone. So this would be left homonymous hemianopia. And same way, here we have the visual field defect on the right side of right eye and right side of left eye. So this would be right homonymous hemianopia, right? So then we have another entity. This is called the heteronymous hemianopia. Here, the field defect is on different sides in each eye. So for example, here we have the visual field defect on the right side of right eye and left side of left eye. So this would be a heteronymous hemianopia. And since it is on the temporal aspect of both the eyes, we call it a bitemporal hemianopia. Okay. And the exact opposite would be a binasal hemianopia, where the field defect is on the left side of right eye and right side of left eye. Okay. So any visual pathway lesion which is beyond the optic chiasma beyond the like optic tract, lateral genital body, optic radiation, or in the visual cortex, we get homonymous field defect, and that would be on the contralateral side. Okay. So we'll these are the various visual field defects that occurs along the visual pathway, and we'll see how it happens in due course. So the next thing that we need to understand is whether the field defect is complete or incomplete. So when the hemianopia extends from top to bottom, it covers the entire visual field. It is called complete hemianopia. So this would be a right complete homonymous hemianopia, right? So what happens if there is some area of normal visual field? Then we call it incomplete. That is, the visual field has started extending from superiorly. It has progressed beyond the horizontal raphe, and it has not reached the inferior portion. So then we call it as incomplete. So this is the second classification. So then how do we call this visual field to be? As it is on the left side. So it would be left. It is on left side of left eye and left side of right eye. So it would be homonymous, and it's incomplete. So left incomplete homonymous hemianopia. So next we'll understand what is congruous and incongruous. Congruous means the both eyes are symmetrical. Here we can see it is symmetrical between the right eye and the left eye. So this would be a congruous field effect. And here we can see one side it's a complete hemianopia and the other side it's an incomplete hemianopia. So there is some asymmetry there. So therefore we call this as incongruous field effects. So the more the posterior the lesion is, like in the posterior part of the optic radiation or the occipital cortex, we have a field effect which is more congruous. The more anterior, that is close to the optic tract or the lateral genital body area, then we'll have a more incongruous field effect. And generally we say congruous and congruous for incomplete hemianopias. So for example, when we looked at this complete hemianopia here, it is symmetrical. So, but we do not say whether it is congruous and incongruous because it does not have any localizing value. So this can be anywhere behind the optic chiasma. Okay. So generally now we'll just go through a little bit about the visual pathway. So generally visual pathway starting from the visual fields. It falls inverted on the retina, and once it's the axons of the ganglion cells from the retina pass as the optic nerve, the nasal fibers start crossing at the chiasma, and then we have the optic tract, following which we have the lateral geniculate body, and from there we have the optic radiation which passes through the temporal and the parietal lobes, ultimately terminating in the visual cortex. Okay. So these are the various field effects. So before we go on to the field effects as such, two more important points that we need to know. One, the image on the retina is inverted. So whatever is there superiorly will fall on the inferior retina. Whatever is there nasally will fall on the temporal retina. Okay. Like for example, this building is falling inverted on the retina. And then we need to understand something about the corresponding points. Suppose there is an object in space which we are focusing. So that object will fall on the fovea of both eyes. So therefore, the fovea of both eyes are called corresponding points. So corresponding points are those points in the retina which has got the same visual direction. So consider there is another point here which is there on the left side of the point we are fixing. So where will it be focused? So we connect the point with the nodal point and extend it into the retina. So it falls at a point which is nasal to the fovea. Okay. And similarly, the same point will fall at a point which is temporal to the fovea in the right eye. So these points, one in the nasal retina and the other one in the temporal retina, they are called corresponding points because they have the same visual direction. Okay. So look at this diagram here. So there we see a mountain here. So when we are focusing at that particular mountain, both the fovea are looking at that particular point. So now someone can unmute and tell me, where does this moon fall? I'll wait. In the right eye and in the left eye. When we are focusing at a distant object like the mountain here.
Good morning, sir. This is Bharadwaj here. Sir, on the right side. Hello, sir.
Yeah, tell, waiting.
So on the right side, it will fall on the nasal retina, and the left side fall on the temporal retina.
You have to be more specific. Which nasal?
Sir, inferior nasal in the right eye and inferior temporal in the left eye.
Yes, correct. So in the right eye, it will fall in the because it is in the supero-temporal field for the right eye, it will fall in the infranasal aspect. Same way for the left eye, this moon is in the supranasal aspect, so it will fall in the infratemporal quadrant of the left eye. So those 2 points, they are also corresponding points. So the point that I want you to understand is that corresponding points, like it is there in the infranasal on one side and infratemporal on the other side. It's not infranasal and supratemporal. It's not exactly opposite, right? Okay. So now we'll understand another concept here. So as we all know, visual field is highest in the temporal quadrant. So around 100 degrees temporally. Then we have 60 degrees nasally, 60 degrees superiorly, and 75 degrees inferiorly. And we also know that the retina is slightly closer to the limbus on the nasal side. For example, it's around 6 millimeters from the limbus on the nasal side and 7 millimeters from the limbus on the temporal side. So there is 1 millimeter of extra retina on the nasal side. So consider there is an object here in the extreme right visual field. So that object is going to fall on the nasal retina, on the extreme nasal retina of the right eye. And similarly, the same object will also fall on the extreme temporal part of the eye in the left eye. But as we can see, there is no retina here. So there is no perception of this image from the left eye. So this is called the uniocular field. Moreover, there is also this nose which blocks the rays coming from the extreme temporal aspect. Okay, so this portion of the retina corresponds to the uniocular field of vision. We'll see the relevance later. So any defect which affects this portion will lead to a visual field defect in the extreme temporal side on extreme temporal side. That's all. Okay. So next we'll go on to the arrangement of the fibers. So first we'll look at this diagram here. So this they have divided into 4 portions: superior, inferior, nasal, temporal, temporal and nasal. So as we all know, the disc is on the nasal side and macula is on the temporal side. So when we draw the visual fields, the macula is at the center, right? Okay. So now all ganglion cells which are arising from the macula and axons of those ganglion cells will directly go to the temporal aspect of the optic disc. So any macular fiber and the papillomacular bundle will reach the temporal aspect of the optic disc. Those fibers, those ganglion cells and its axons which are on the temporal side will arch above and below this papillomacular bundle and reach the superior and inferior parts of the optic disc. So, but another point to note here is it's temporal to the macula. Like there is a vertical line here. Any point which is temporal to the macula, not temporal to the optic disc. It is temporal to the macula. All fibers which are there temporal to the macula will arch over and go to the superior and inferior aspects. And another important point that we have to notice, the horizontal raphe is strictly respected. There is no crossing of the fibers above and below. Okay. So now we have seen all these three, and whatever is remaining, that is whatever is on the nasal side of the macula will arch over and go to the nasal aspect of the optic disc. Okay. So now we saw that the uniocular fibers are there on the nasal side, right? So it is on the nasal retina. So these uniocular fibers also go to the nasal side, obviously. So arrangement of fibers will be like this. When we see a cut section of the optic nerve head, the macular, upper macular fibers will be on the temporal side, lower macular fibers will be on the lower temporal side, and this would be the cup here. And all the fibers which are arising from the temporal, upper temporal quadrant will go to the superior aspect of the disc. All fibers which are arising from the lower temporal quadrant will go to the inferior aspect, and all the nasal fibers will go to the nasal side. And when we look at this particular diagram here, we can see, so the ganglion cell which is in the periphery of the retina will take a long intraretinal course and go to the border of the optic disc. Whereas a ganglion cell which is lying closer to the optic disc will take a shorter course obviously and go to the central part of the optic disc, that is closer to the cup. Okay. So these uniocular so these uniocular nasal fibers, as we saw, are in the extreme periphery, right? So since they are in the extreme periphery, they go to the outer aspect of the optic disc here. So this, your understanding, arrangement of fibers in the optic nerve head. Any doubts in this? Okay. Shall I proceed?
So Bharadwaj here, sir.
Yes, tell me.
Sir, is there any crossover, sir, just before entering the disc? Those fibers like go like part of the fibers from the nasal side like will enter towards the temporal side of the disc, or like the temporal side of the fibers will enter from the nasal side of the disc. Like if you consider disc, if you divide the disc into two halves,
Yeah.
like temporal fibers, are they entering only from the temporal side, or they are little crossing over before entering the disc?
No. Whatever is there, temporal means temporal to the macula, you're telling?
Yes, sir. Temporal to the macula, the fibers before entering the disc, are they entering like temporal side of the disc, or they're like crossing towards the nasal side of the disc and entering the disc, sir?
No, they go to the superior and inferior. You divide the disc into 4 quadrants like this.
Yes, sir.
Make an X. So superiorly and inferiorly it will go. There is no crossing over. Probably
Okay,
a little bit across the center it will go.
Okay, sir.
Till around 1 to 5 o'clock.
Okay, sir. Thank you, sir.
So this is what we saw at the level of optic nerve head. So as the optic nerve, after the optic nerve, we have the retrobulbar portion of the optic nerve. So what happens here is that these macular fibers, which are there temporarily, it will migrate towards the center. So that's the only change that is going to happen. So these temporal fibers, which are there in the superior aspect, will slide towards the temporal side, and the macular fibers come towards the center. So that's nasal fibers stay like that. So this happens in the retrobulbar portion of the optic nerve. So suppose consider this point 2. So there is an optic nerve transection. So what happens? All the fibers are getting affected. So there will be ipsilateral monocular blindness on that particular side, and there will be there will be normal vision and normal visual field in the other eye. So it need not be a complete transection. So there could be certain fibers which are getting affected. So depending upon which fibers are affected, there will be a particular pattern of field effect. So that's why in optic neuritis, you can get any type of field effect in that particular eye, whereas the other eye is normal. Okay. So any lesion which is anterior to the chiasma will cause an ipsilateral monocular field effect. So what happens when it is closer to the chiasma? So we get something called the junctional scotoma of trachea. So we'll before we need to we understand this, we need to know a little bit about the chiasmal architecture. So consider this was the optic nerve head. Sorry, this was the retrobulbar portion of the optic nerve that we saw. So the nasal fibers are nasally, temporal fibers are there temporally. Centrally, we have the macular fibers. So we saw earlier that the nasal fibers are going to cross over to the opposite side in the chiasma, right? So, but it is not a direct course. Instead of going directly, the infronasal fibers, right, which corresponds to the supratemporal visual field, they instead of going directly to the optic tract, it takes a U-turn, goes into the opposite side optic nerve for some distance, and then goes along the periphery to the optic tract on the opposite side. So this U-turn that is being taken is called the anterior knee of Willebrand. There is a posterior knee of Willebrand where the supranasal fibers go on the same side optic tract for a little bit and go to the opposite side. But this does not have much of a clinical significance. But here there is a longer intra-optic nerve course. So and also the macular fibers are also crossing. The nasal macular fibers also cross over to the opposite side. So consider there is a lesion here. So what happens? As we saw, when there is a complete transection, we know that there will be ipsilateral monocular blindness on this side. And the infronasal fibers of the other eye are going to get cut. So what field effect will we get?
Other eye supratemporal quadrant.
So other eye supratemporal quadrant will have a scotoma. Right? So depending upon the amount of compression in the left eye, we can get any type of field effect. So if it's completely compressed, you'll get a total blindness. If it's incompletely compressed, depending upon the nerves which are getting compressed, you'll get a particular pattern of field effect. But more importantly, we'll get the other eye junctional scotoma here. Most commonly, this happens in case of tuberculum cellum meningioma. Okay. So then we'll go to a complete compression of the optic chiasma. So optic chiasmal compression does not happen overnight. Like it is usually due to compression by an enlarged pituitary gland, craniopharyngioma, or a meningioma. So what happens when the nasal fibers of both sides are getting, this is a nasal crossing which happens in the optic chiasma. So when there is compression of the optic chiasma, what happens? Both sides nasal fibers are going to get affected. So when the nasal fibers are going to get affected, it is a temporal field that the person does not see. So that's why we get a temporal hemianopia on both sides. So this we call it as a heteronymous defect. This is a bitemporal hemianopia. Okay. So now we will understand what is the difference between a pituitary adenoma or a craniopharyngioma. So pituitary like as we saw in the previous diagram, this is the chiasma here, and below the chiasma we have the pituitary gland. Now when the pituitary enlarges slowly, it is going to compress the chiasma from the bottom. So inferiorly we have the inferior fibers. So inferior fibers correspond to which part of the visual field? Superior part of the visual field. So this is the pituitary adenoma here. So inferiorly there is going to be compression. So initially the field effect will start in the superior aspect. It will be a bitemporal hemianopia, but still it will start in the superior aspect and progress like this towards the inferior side. So this is in case of a pituitary adenoma, whereas the exact opposite happens in case of a craniopharyngioma, where the craniopharyngioma is going to compress from the top. Because it is going to compress from the top, the superior retinal fibers are going to get affected. That means initial field effect will appear inferiorly, and as the chiasma gets compressed due to enlargement of the craniopharyngioma, the field effect progresses towards the superior side. So this is the difference between a field effect in a pituitary adenoma or a craniopharyngioma. This everyone are understanding? Any doubts in this?
Understanding, sir.
No doubts?
No, sir, no.
Shall I proceed?
Yes, sir.
Yes, sir. Please proceed, sir.
Okay. So next we'll understand what is a prefixed or a post-fixed chiasma. Normally, the pituitary gland is located exactly below the optic chiasma. Now, when the chiasma is slightly anterior, what happens? This is what we call as a prefixed chiasma. So when the pituitary gland enlarges, it is going to compress the posterior portion of the optic chiasma and the optic tract, leading to visual field effects similar to an optic tract lesion. So that is a prefixed chiasma. And post-fixed chiasma is that the chiasma is behind. So when the pituitary gland enlarges, it is going to compress the junction of the optic nerve and chiasma. So this will cause a junctional scotoma, right? So this is with regards to optic chiasmal lesions. In addition to these visual field effects, what else do we get? So as we saw, nasal fibers and the macular fibers are going to cross in the chiasma. So now when the chiasma gets compressed, both these fibers are going to get atrophied. So nasal fibers, as we saw, goes to the nasal aspect of the optic disc. Macular fibers, as we know, goes to the temporal aspect of the optic disc. Now when both these fibers are getting damaged, here we'll get a pallor, again here we'll get a pallor. So this is called a bow tie or band optic atrophy. So here we can see superiorly and inferiorly there is not much of pallor, whereas nasally and temporally there is significant pallor here. So this suggests there is a optic chiasmal lesion. And then we need to understand this concept here. So consider, leave out the optic chiasma part now. Consider there is an object T, and this object T you are fixing. One minute.
Sir, please explain that bow tie, sir.
Okay. So in bow tie optic atrophy, what happened? What we saw is that in the chiasma, we are seeing that the nasal fibers are going to cross to the opposite side. So nasal fibers of left eye and nasal fibers of right eye are going to cross. And the macular fibers are also crossing, right? So now when there is a compression in the chiasmal area, both these nerves are going to get atrophied. That's how optic atrophy happens, right? So that's called primary optic atrophy. So behind the optic nerve head, when there is a lesion, it causes primary optic atrophy. So now when there is a compression here, those nerve fibers, those axons are going to get atrophied. So when we saw the arrangement of fibers, we saw macular fibers are going to the temporal aspect of the optic disc, and nasal fibers, which are the crossing fibers, go to the nasal aspect of the optic disc. Superiorly and inferiorly, we have the temporal portion, like temporal axons or the ganglion cells, temporal to the macula, will cross over and go to the superior and inferior aspects. Now these are fibers which are not going to cross. They are going to go on the same side. So any optic chiasmal compression, no? So this is the lateral part of the optic chiasma. So they go undeviated. Again, here also they goes without crossing. So when there is a lesion in the central part of the macula, those fibers are not going to get affected. Therefore, they do not have any pallor on that particular side. So superiorly and inferiorly, we do not have pallor. Whereas, so this is the nasal side, there is some pallor, and this is the temporal side where the macular fibers are getting atrophied. Nasal side, nasal fibers are getting atrophied. That's why we have a bow tie pattern of optic atrophy. This happens in a chiasmal lesion, central chiasmal lesion. Whereas when it involves the entire chiasma, includes the lateral fibers also, then we'll get a total pallor. Okay.
Okay, sir.
So now forget about the chiasma. You're looking at an object T, and this object T, since you are focusing on that object T, it is going to fall in the fovea of both eyes. So it is falling at F and F. So consider while looking at T, there is an object behind T, O. So when this point O, when we join with the nodal point of the eye, it falls on the nasal retina of one eye, of the left eye, and again it falls on the nasal retina of the right eye. So as we saw in a chiasmal lesion, this nasal retina is non-functional because that is getting atrophied because of pituitary compression there. So because of this, whatever object is there exactly behind the point of fixation, they are not able to see. Right? This is called post-fixation blindness. And this again happens in an optic chiasmal lesion. Apart from this, there is also seesaw nystagmus which can happen in an optic chiasmal lesion. So everybody are clear with the optic chiasmal lesions? Can we proceed further?
Please proceed, sir.
The seesaw nystagmus, only the seesaw nystagmus parts once again, sir.
Seesaw nystagmus, I just told I don't have a video for that. So there's no specific reason why seesaw nystagmus has to happen. It is just that seesaw nystagmus is seen in optic chiasmal lesion. That's all.
Okay, sir. Thank you, sir.
Okay. So this is the arrangement that we saw. All the nasal fibers, including the nasal macular fibers, are going to cross at the region of optic chiasma. Right? Now we'll understand what happens in the optic tract. So in the optic tract, again, what happens is the macular fibers will move temporally. Okay. So we can see here. Apart from that, there is a twisting of the nerve. So for example, this is the optic nerve there. We see the temporal fibers are there temporally. Now, because of the twist, instead of appearing temporally, it goes slightly superotemporally. Okay. There is an inward twist of both eyes. Apart from that, we don't differentiate into upper nasal and upper temporal. So what happens here is that we call it upper peripheral and lower peripheral. So this I'll explain now. So the consider this upper portion. We'll first listen to the upper portion. There is the upper temporal fibers which are coming from the same side, and upper nasal fibers which are going to come from the opposite side. So they both sort of intermingle with each other, and that's why there is no specific differentiation in this portion. So we call it upper peripheral fibers. Okay, and again the lower temporal from the same side mingles with the lower nasal from the opposite side, and we call it lower peripheral. In the optic now, macula was in the center. Now it has again moved towards the temporal side. And as we saw, the extreme nasal portion on the so the extreme nasal periphery will have the uniocular nasal fibers. Again, since it's a nasal fiber, it is going to completely cross over to the opposite side. And we see those nasal fibers to be in the most infranasal portion of the optic tract. So this is with regards to the arrangement of the nerve fibers in the optic tract. Now consider a lesion which has affected the optic tract here, completely damaged the optic tract. So what happens? The temporal fibers from the same side and the nasal fibers from the opposite side are going to get affected. So when the temporal fibers from the same side gets affected, it will be the nasal visual field, right? So for the left eye, it's a nasal visual field that is gone, and the nasal fibers from the opposite side, which means it's a temporal field of the opposite side. So temporal field of the right eye is going to get affected. So in an optic tract lesion, we'll have a homonymous field effect on the contralateral side. Here there is a left optic tract lesion and we have a right homonymous hemianopia. Okay, it's simple here. Apart from that, we already told that more anterior the lesion is, more incongruous it will be, and as we go posterior, it will become more congruous. Apart from that, there is also the Wernicke's hemianopic pupillar reaction. So this is simple, like you shine light into the affected retina. Suppose you shine a thin beam of light into the temporal retina here. Since it's already damaged, there is no pupillar reaction. Whereas when we shine light into the nasal retina, it is going to the opposite side, so there will be a pupillar reaction. So this is Wernicke's hemianopic pupil, but it is very difficult to elicit because it is difficult to put a thin beam of light only on one particular side of the retina. There will be some dispersion of light. So this is mainly for theoretical purposes. So next we'll go on to the lateral geniculate body. So this is quite complex. So follow with me, and if you have some doubts, please stop. So we saw in the optic tract, the fibers are there, the macular fibers are there supratemporally. Now there was an inward twist from the optic nerve to the optic chiasma to the optic tract, and again the inward twist continues. So these supratemporal fibers will become superior fibers here. Just look at this diagram here. So macular fibers will come to lie superiorly, and whatever was there as the upper fibers will come to lie medially because of that inward twist. So simple here. Okay. And the uniocular fibers will lie in the lowermost portion. Apart from this, the lateral geniculate body has got various laminae. So they have named it as 1 to 6. So here the crossed fibers go to laminae 1, 4 and 6, whereas the uncrossed fibers go to laminae 2, 3 and 5. Okay. So consider this upper peripheral quadrant here, upper peripheral area. There is these includes same side upper temporal fibers and opposite side upper nasal fibers. Okay. So these upper temporal fibers which are coming from the same side are uncrossed and therefore will go to lamina 2 or 3 like this. Okay. Lamina 5 is mainly for macular region. So either it goes to lamina 2 or 3. Whereas the upper nasal fibers which are coming from the opposite side will cross over and come to lie at lamina 1 or 4, like 1 or 4 on this side. So this side it will be the crossed fibers. So that's how these are fibers which are coming from corresponding points, right? So upper temporal on the left side and upper nasal on the right side would be, there will be corresponding fibers, and these corresponding axons from these corresponding fibers come to lie closer in the area of the lateral geniculate body. Okay. So consider the lateral geniculate body is totally gone. So what will you get? Similar to an optic tract lesion. So it's the same fibers which are going to the lateral geniculate body. So similar to the optic tract lesion, it will be the same side temporal fibers. Therefore, opposite side field effect will be there. That is nasal field effect on the left eye, and in the right side, it will be a temporal field effect. So again, this causes a contralateral homonymous hemianopia. So this much is okay. This much is easy. Now consider the lesion which is going to affect only this portion of the lateral geniculate body. Okay. This is mainly for understanding purpose. There is no particular lesion which affects only one side. Okay. So consider there is a lesion which is affecting this particular side. Okay. So what happens? The lower fibers are going to get affected. Lower fibers are affected means like it will lead to an upper field effect. whereas the upper fibers are getting spared. Because these upper fibers are getting spared, the lower field will be spared. So in that contralateral homonymous hemianopia, the lower fibers are getting spared here. Lower field is getting spared because the upper fibers are getting spared, right? This produces a contralateral superior quadrantronopia. Okay, this much is clear. Any doubts? I'll wait. Anybody want to ask questions? Shall I proceed?
Yes, sir.
Okay. So now consider so we saw one half of the lateral geniculate body. Consider lesion which is going to affect only this portion of the lateral geniculate body. So it is going to affect the lowermost portion. So half of the lowermost portion is again going to get spared. Okay. So it will produce a field effect like this. Okay. Now based on this concept, we'll understand the blood supply of the lateral geniculate body. So lateral geniculate body has got two arteries which are going to supply, the anterochoroidal artery and the lateral choroidal artery. So the anterochoroidal artery supplies the lateralmost portion and the medialmost portion of the lateral geniculate body, and the central portion is going to get supplied by the lateral choroidal artery. So now the red one is what we saw. In the extreme lateral portion, it corresponds to the superior type of sectronopia. Okay, but and again the color coding is self-explanatory here. So consider there is a lateral choroidal artery occlusion. So it will cause damage to the central part of the lateral geniculate body. So when the central part of lateral geniculate body is affected, you will get a field effect which is somewhat like this, right? So this is called homonymous horizontal sectoronopia. Okay. The superior and inferior parts which are supplied by the anterochoroidal artery are going to get spared. And what happens if the anterochoroidal artery is blocked and the lateral choroidal artery is spared? We get a field effect like this, which is sector sparing homonymous hemianopia on the contralateral side. Okay. If altogether it's blocked, we'll get total contralateral homonymous hemianopia. Whereas when there is a lateral choroidal artery alone, we get a sectoronopia, and if it's an anterochoroidal artery, we get a sector sparing homonymous hemianopia. Okay. So this is understandable. Lateral geniculate body. Sectoronopia happens in a lateral geniculate body lesion. So that much we have to know. Okay. So next we'll go on to the optic radiation. So consider we saw this diagram already. So whatever fibers are there laterally in the lateral geniculate body, they pass antero-inferiorly. Like this is the fibers which are going to come. So antero-inferiorly it goes and winds around the anterior tip of the temporal horn of the lateral ventricle and passes deep in the temporal lobe. Ultimately, it reaches the occipital cortex. Whereas those fibers which are there medially, which corresponds to the upper part of the optic nerve. So those fibers will directly go through the parietal lobe and ultimately terminate in the visual cortex. Okay. So these are the two radiations. So these optic radiations are the third order neurons. So till the lateral geniculate body, the axons of the ganglion cells will come. It's the same neuron which is extending from the ninth layer of the retina to this one. Okay. And yeah. So what happens if there is a temporal lobe lesion? So if there is a temporal lobe lesion, these temporal fibers are going to get affected. That is lower temporal. Sorry. So the temporal part of the lateral fibers which are coming from the temporal part of the lateral geniculate body. That is lower portion of the visual, lower portion of the optic nerve. So since these are getting affected, we'll get a superior field defect. Okay, so we'll get a contralateral superior quadrantropia. Whereas when there is a parietal lobe lesion, it's the superior fibers. Superior fibers means we get an inferior field defect. We get a contralateral inferior homonymous quadrantropia. As we go more posteriorly in the optic radiation, both these fibers come together and ultimately it leads on to a contralateral homonymous hemianopia, which is complete. Okay, this 8th. So what other features are there in a temporal lobe or a parietal lobe lesion? In a temporal lobe lesion, apart from the pie in the sky, we also have complex visual hallucinations. So complex means they see images of objects, person, or landscapes like that. So that would be complex visual hallucinations. Whereas in a parietal lobe lesion, the additional features that can be there are the asymmetric optokinetic nystagmus. We all know in the pursuit movements start from the parietal lobe. Now, when the parietal lobe is affected, the pursuit movements is affected. That's why we have an asymmetric OKN. The second one that we have is a Cogan's sign of spasticity of conjugate gaze. So normally in a Bell's phenomenon, what happens? When we do a forced lid closure, the eyeball rolls upwards and outwards. So now in a parietal lobe lesion, what happens is there will be conjugate deviation of eyes to the opposite side. So this is called the Cogan's sign of spasticity of gaze. And the other one that we have is called visual inattention. Suppose there is an object in the affected visual field, in a patient with a parietal lobe lesion may still be able to see it. Whereas when there are two objects, one on either side, one in the affected field, one in the normal field, patient will not be able to see the object in the affected field. So this is called visual inattention. Okay. So what was that? Optic radiation fiber arrangement. Okay. So in the optic radiation, what happens? So this is what we saw in the lateral geniculate body. So in the lateral geniculate body, we have the upper fibers, that is from the optic nerve I am telling. The upper fibers come to lie medially and the lower fibers of optic nerve comes to lie laterally. And these lateral fibers, lower optic nerve fibers, will pass through the temporal lobe inferiorly, like this. Now, when these fibers are going to get affected, see, this is the lower macular fibers, lower peripheral, that is lower temporal from the same side and lower nasal from the opposite side, right? When these are going to get affected, we'll have a contralateral upper quadrantropic field defect. So this is with the temporal lobe lesion. Whereas in a parietal lobe lesion, what we'll have is a upper fibers. In a parietal lobe lesion, these are the fibers which are going to go to the parietal lobe. So we have upper macular fibers, upper peripheral. Upper peripheral includes upper nasal from the opposite side and upper temporal from the same side. And when this is going to get affected, we'll have a contralateral lower quadrantropia. So that's what we have here. This would be a parietal lobe lesion. We'll get a contralateral pie in the floor. Okay. Is it fine? Explanation is okay for
Yes,
optic
sir.
radiation? Okay. Now we'll go on to the visual cortex. So in the visual cortex, we saw in the visual cortex what's going to happen is the upper fibers are going to go above and lower fibers are going to go below, and the brain is going to invert the image. So that happens by the brain itself. So we'll see how the fiber ends. So majority of the macular fibers will go to the posterior most aspect of the visual cortex. So there is an occipital tip lesion, the macular fibers are going to get affected. And there is a large representation of the macula in the occipital cortex. Okay. And just anterior to those macular fibers, we see the upper peripheral fibers and the lower peripheral fibers. And even more anterior, that is the most anterior most portion, will have the uniocular fibers. Uniocular means uniocular nasal fibers from the opposite side. Okay. So consider there is a lesion which is involving the entire macula here. What will we get if there is an entire cortex? So what will we get is contralateral homonymous hemianopia. But apart from that, we have something called a macular sparing. So now why should macular sparing happen? So macular sparing happens only in a cortical lesion. Okay. So why should macular sparing happen? So the various reasons that has been proposed are, first, there is extensive macular representation. So a lesion has to be large enough to affect the entire macular area. So that is one reason. The other one is there is blood supply from both the middle cerebral artery and the posterior cerebral artery. So both vessels may need to be affected. And the next one, what they say is there is crossing of the macular fibers. And there is bilateral representation of the macula. The crossing happens through the splenium of the corpus callosum. So they say the macular fibers are represented on the both occipital cortices. And the last mechanism that they say is the shift in ocular fixation. So what they suggest is, since there will be a homonymous hemianopia which involves the center, what they say is that an extrafoveal element tries to take up fixation so that patient has some central vision. So that's why they have macular sparing. So mainly three mechanisms. So one is the extensive representation, the other one is the double blood supply, and then we have got the crossing of the macular fibers. So this would be a late onset. And what happens if there is a lesion which involves the anterior most tip of the occipital cortex? So we saw this diagram already. So when the anterior most tip of the occipital cortex is affected, it will lead to a temporal field effect on the contralateral side, like this. Okay. So this is the only place where we get monocular field vision in a retrochiasmal lesion. Monocular field defect in a retrochiasmal lesion. Okay. So this is an isolated temporal crescent which extends from 60 to 100 degrees on the contralateral side when there is a lesion of the occipital cortex, anterior tip of the occipital cortex. Okay. So apart from this, visual cortical lesion also causes simple visual hallucinations like flashes, halos, like that. Whereas complex visual hallucinations are seen in a temporal lobe lesion. They can also have Anton syndrome, that is, there is denial of blindness, and there is something called the redox phenomenon, where stationary objects are not perceived in the defective visual field, whereas moving objects are perceived within that defective visual field. So this would be redox phenomenon. Okay. So any doubts with this? So we have seen the visual pathway. Just 2-3 slides about the other visual field effects that can happen in case of a chiasmal that can happen in neuro-ophthalmology. So consider this: there is a 60-year-old male who is a known diabetic for 10 years, and he has uncontrolled diabetes. Is a chronic smoker. Complains of painless, sudden diminution of vision in the left eye. So what would be the diagnosis here? You can unmute and tell. Anybody? No one?
Sir, give more time, sir.
Okay, you have a field effect like this also in this patient. So this is a patient with anti-ischemic optic neuropathy. So more common when there is uncontrolled systemic illness in elderly individuals, where there is occlusion of the short posterior vessels. So this causes a altitudinal field effect. And here we have a 30-year-old female who complains of sudden painful blurring of vision for 4 days. And fundus shows dyschedema, and you have a field effect like this. So what is the probable lesion? What type of field effect is this first?
So quadruple sectornopia.
Yes, please. What sectornopia?
So quadruple sectornopia.
I'm sorry, I'm
So
not
due to lesion in anterior choroidal body.
Okay. So sectornopia means sectornopia will be like this. Okay. So that would be a sectornopia. So here what we have is that this is the temporal side and this is the nasal side. So blind spot will be somewhere around here, around 12 to 17 degrees temporally, 2 degrees above and 5 degrees below. So there is a field effect which is involving the blind spot and which is extending towards the center. So this is called centrocecal scotoma. Cecum means blind spot. So this is the centrocecal scotoma here. Okay. Okay. So patient, this is a classical case of optic neuritis or papillitis. Papillitis, as I told, can cause any type of field effect depending upon what fibers are getting affected on that side. But it would be monocular. Most common field effect is a centrocecal scotoma, but it can cause a altitudinal hemiopic field effect or even total blindness on that particular side. Okay. So these are examples for an enlarged blind spot. So here we can see papilledema, and papilledema, enlarged blind spot happens because there is edema, there will be sliding of the photoreceptors here. There will be mechanical alteration of the retina which is around the optic disc. That's why the blind spot appears enlarged. And also when there is a large peripapillary atrophy where there are no rods and cones, obviously that area will be scotomatous around the optic disc. So this can also cause an enlarged blind spot. Glaucoma can also cause an enlarged blind spot. There are various other reasons, but we need to see these. And lastly, we'll see this scenario here. A 60-year-old male who is a chronic smoker complains of gradual, painless, progressive loss of vision over 1 year. And you get a fundus appearance like this. So what is the diagnosis? Consider visual acuity is 612 both eyes. So this is a patient with the optic neuropathy. It could be toxic or nutritional optic neuropathy also presents like this, where there will be temporal pallor of the optic disc. So what happens is that this tobacco, no? So what this tobacco does is it affects the axial portion of the retrobulbar optic nerve. Okay. So now what does the axial portion of the retrobulbar optic nerve correspond to? So we saw in the arrangement of nerve fibers, right? Want to know what does the axial portion of the retrobulbar optic nerve correspond to? What fibers are going in the axial portion? Yes, good. We saw that the macular fibers, the macular fibers, it is going to go directly to the temporal side. Again, the macular fibers here are going to go directly to the temporal side. In the optic nerve head, there will be temporally, but as we go behind the optic nerve, that is in the retrobulbar portion of the optic nerve, it slides towards the center, and the temporal fibers which are there superiorly slides towards the temporal side. Now, in case of tobacco amblyopia, what happens? This axial portion undergoes degeneration. And what happens? That axial portion corresponds to the temporal aspect of the optic disc. So that's why this area is atrophic. So that's why vision is also low. So when there is a temporal pallor, we need to ask for smoking history also. Okay. So this is what we saw. This portion is going to get affected in case of a toxic amblyopia. Okay. So that's it with the presentation. So if you have any doubts, we can discuss.
You can unmute and ask the questions.
There is no specific reason for arrangement of LGB layers. It is how it is it's normal anatomy. So the main reason is that the corresponding retinal elements have to come closer. So any lesion which is beyond the lateral geniculate body, as it goes beyond the lateral geniculate body, it comes still closer. So that's why we get more amount of congruous field effects.
Sir,
Sir, tell me, sir.
so what is this nomenclature pi has got to do with this field effect? Pi in the sky and pi in the floor.
A pi is actually a sector. So I'll share the screen again. Sir. So when these fibers which are going through the temporal lobe are going to get affected, it's a lower portion of the contralateral side of the contralateral field which is getting affected. So that's why we get the upper contralateral quadrant myopia. So a pie, it's like a pie. It's like a piece of the pie, and it's on the upper aspect. That's why you call it pie in the sky. And this is also a pie in the parietal lobe lesion, but it affects the superior fibers, which means it's the inferior field. So that's why it is called a pie in the floor. It is in the lower aspect, so it's called a pie in the floor.
Thank you, sir. Sir, you use two terms, optic neuritis and optic neuropathy. When to use those? Where to use those two terms, neuritis and neuropathy?
Sir, neuritis is when there is inflammation. So like mostly it's idiopathic. So that's why we call it optic neuritis. So however, when there is no inflammation, like for example, tobacco amblyopia, toxic optic neuropathy, so those things, there is no active inflammation. It is due to direct degeneration of the axons. Because of this degeneration without inflammation, we call it neuropathy.
Thank you, sir. Any more questions from the audience? Dr. Kalavani, madam. Hello. So we'll wait for a few moments to take in more questions, sir.
Yes, sir. We can wait.
It seems like there aren't any more questions.
Okay, sir. So we'll close the session. Thank you very much. All the best.
Thank you, sir. I thank the Dean RMMC and Dr. Junior Sundaresh, who has been very helpful in convening this meeting, Zoom meeting, and the AAA Scientific Committee for selecting the speakers and the topics. And above all, I thank all the participants. Thank you all, and we'll leave the meeting here. Thank you very much.